them with no challenge. When we entered 2000 to continue to pay them, I think up until July, yes, last year. And since then, we have still been working, hoping that the Ministry of Health, Ministry of Finance will absorb these names onto government payroll, so that even the next 400 or so that was on Director Obi's list to join the 250 will also be brought on board. But I am sure you all see that the government has challenges in doing the recruiting and granting financial clearance for all categories of staff. So unfortunately, these staff are also in that bracket. I have engaged him severally on this, and he said they are working on it to pay. I have engaged him severally on this, and he said they are working on it to pay. So we are having local arrangements across the region. We don't even have one standard arrangement of paying these physician assistants. So some hospitals are advancing them monies, some districts are also advancing them monies to be able to make them also live, because they cannot go on without salaries. It is something that actually sets our teeth on edge. But Director, I want you to assure the physician assistants, and for all of you here who have some of these physician assistants, they are not an addition, they are not a different brand, they are not NOP physician assistants. They are part of us. They are recruited through normal processes, legitimate processes. It's just that that transition of making their salaries come from Controller and Accountant General has become a challenge. But I know that the Director General will address this thing very soon. Director HR is here. If he wants to add anything, I am sure he would. Thank you.
Director HR, we give you the opportunity to.
Thank you. Blessed assurance. Yes, so the good news is that our minister has been able to raise this issue at cabinet. In the next week or two, there's going to be some opening. And the assurance is that even if the service will be given total of 500, 250 is already taken. Because the PAs that are on local arrangement now, we have their particulars, everything. So as soon as that opening is done, we are going to be pushed. So let us, I will not give date, I will not give deadline. I don't want to be a prophet. A prophet will run away. So the issue is that the matter is coming to an end, and it's going to be very soon. So just as Director said, they are part of us. In fact, the appointments, when finally issued, will take notional effect from when they started. Which means that if you have somebody who has worked for more than 1 year, in the next year the person is going to go for promotion, just as any other staff. So please, their treatment should not be different from what we are giving to us. Thank you.
So can we take the second round of questions and clarifications? Yes, I think yes. There was one from Metro Hospital.
That's what I have to address.
Metro is actually a help, but they don't have.
And the lady said they are in the district hospital for this supposed to be a help. And that's not what the implementation guidelines is. There's, when you look at the manual, there is a consensus framework. That's the configuration chart. So the hospitals provide clinical support to the hubs. And then also referral support. So that's the role of the hospital. And the hospital is not, it can be a hub at certain cases, but in your case, there's a hub and you are only providing clinical support and referral support. And then also the Metro Directorate. Director Sami, then let's let Director Sami address that one. Why there's no hub linked to.
So for the NOPs, Central Region, we're giving 29 hubs. And we have to, because 22 districts, we have to share it across. So for Campus Metro, you are not a hub. But then when it comes to supporting supervision, per the peer review checklist, you are supposed to provide that service to either, no, so for Campus Health Center, ideally, even without the NOP, Campus Metro Hospital, because it's a hospital, it's supposed to provide supervisory services to Adisada Health Centers and any other selected health centers in your catchment area. If Adisada is not in your catchment area, yes, but because it's in the district, you are supposed, the Campus Metro Hospital is supposed to provide that service to any health center and sometimes even to the church within the district. You get it? Yes, so they are supposed, but you can't, because you don't have any in your catchment area, you are not going to provide that service.
How can I share it with my police that I was from
Yes.
But sometimes
yes, I'm saying that. So if it's a metro hospital, once you're in hospital, you are supposed to provide support. So for this one, it's with you and the district director to know which facilities that you are supposed to provide support. But then because you are the district hospital within the district, ideally all the health centers, you are supposed to provide support to them and have a schedule for that. Yes, regardless of whether it has been signed, yes. Regardless of whether it has been signed, you are the district hospital, so you are in charge. Yes. No, but if it's a child hospital, yes, if it's a child hospital, they are also supposed to provide that support. Because some of our district hospitals are child facilities, so they are also supposed to provide that support. And when for peer review, we look for your itinerary for that support. Thank you.
Well, I don't know, but well, I think as a hospital, they are supposed to provide support to the sub-districts. But then, why should it be that they are even not aware that they need to provide those support, and then this matter has to come up at this meeting? I'm surprised. I mean,
I think the gap is that we've had number of trainings here. It depends on who Metro Hospital sent to that training and how that person has got to disseminate information to those on the ground. So I believe that the trainings we've held here, the messages have not gone down well. That is why we are receiving such questions. So probably we have to look at it again. If we could incorporate another training, implementation training.
but I would also think that there should actually be a better collaboration between the hospital and the health directory.
And Chairman, you'll be surprised that even the MESUs, who are supposed to give legal support to the hubs and the networks, some of them still feel that it's not their work. In recent discussions, these issues also came up again. So people do not understand the issues well, in spite of the many dissemination trainings we've had. Thank you.
I think a broader question, maybe the way you should have put your question, and that probably should have come from the district municipal health director, is why is it that the Cape Coast municipality has not been assigned a model health center? What's the problem?
there's a model house. There's a model house. There's a model house.
Thank you. Dr. Dabi, Otusenya. This one, I'm going back a bit to the issue Dr. Brobe talked about with the PAs at the hubs. Mine is maybe an appeal to Director HR. Looking at trends in our policies and how we want to achieve UHC 2 primary health care, it has become very clear that our system heavily relies on peace at the sub-district and the health centers. And talking as a district director who engages a lot with them, I've noticed something and I just want to bring it up. And it has to do with, let me say, their progression in terms of federal studies and federal skills acquisition. It looks like there's no clear pathway for PAs in the service. And as we are relying so heavily on them, if we are not careful and they feel stuck all the time, we might be losing them because it's like they're doing so much. But the service has to plan for them in terms of maybe their career progression. So this one is, and I agree with HR, maybe it can be discussed at higher levels to see what the service is doing in terms of PA's progression. Thank you very much.
Mr. Chair.
Okay. So, yes, I think now we can look at Dr. Kwau's question. That was on the research work. To answer the whys.
Okay, so I think that with this particular implementation research that was done, it was spearheaded with support from World Bank and the Global Fund with Ghana Health Service. It's a fourth phase that I think we're looking out for. But I think apart from that, as a region, we can also take it up. We have a research unit, and we have our money here, so we'll be looking at the other issues and come up with some research topic around that area, and then try and answer some of the issues that have come up in here.
Okay, thank you very much. I think I'm told the Metro Director is here, Cape Coast Metro Director. I'm sure he would want to throw a bit of light on the discussion so far. Why Metro Hospital has not been linked.
Dr. Chair, just before Director Sami comes in, I just want to say that the work on evidence translation that was done 2 years ago, at least started 2 years ago, was done directly with Ubora Institute. I think Mr. Brian Kamega is here. Brian, let us see you. Yeah. So we started this work with them, and they are also working with the 3 research institutes across the country that belong to Ghana Health Service. But it is Dodowa Research Center that is leading this implementation research. Network of practice is heavily embedded in research. Research at the base, that is the formative research, the one that makes us look at what is happening, what do we have. And then the implementation research is the one that we are doing alongside the implementation to learn what works and what doesn't work. It is what works that we are going to scale up. What doesn't work is what we are going to adjust or actually do away with. And then at the end of the period, we shall also have evaluation, that is end-line analysis, to see what have we achieved with all this endeavor. And I must say sincerely that all of you are aware that over the past 1 year, nobody actually took the mic to stand here to mention network of practice, because it looked like we had stopped. And I'm being very sincere. You heard me when I was at headquarters preaching network of practice. Since I have been here, maybe I've mentioned NOP once or twice, but I never preached network of practice because it looked like it was not a priority of the service. And that is why our data has not grown from 2024 to 2026, because we have not, and this one I'm not only speaking about central region, the whole country. It is because we were not told to actively continue working on it. And what we thought we were going to do was free primary healthcare and other new policy initiatives from the new government. And so we have been waiting. But now it looks like network of practice, the approach is going to be continued, but under a new name, and it looks like new guidelines may come up. We do not know. So I cannot tell what the future of the work we are doing with Ubora Institute is going to look like. So if Ebola is going to be supported to continue working with us through that World Bank arrangement, then yes, we can have more targeted research like they have helped us to do. And similarly with Dodowa Research Center. But if that is going to change, then it means that locally we also have to strengthen our research. I am sure you remember that in our extended SMC meeting, we said one district, one research, and you all agreed that we should do it after our performance review, so that we can be targeted in choosing the topics that we are going to work on. So as all of you are clamoring for the why, which is important because we must learn from it. Let us see, maybe by the end of the month, headquarters will give us more information as to how this is going to pan out. And if they are not going to do any research that will include us, then we can also do our own studies to find out why and learn at the local level. So this is what I want to add to what Kathy just said. Thank you, Chair.
Thank you. Director Sami, would you want to throw more light on the ongoing issue?
Thank you so much.
It's not supposed to be a half.
In addition to what the regional director said, during the previous two administrations, we met as a Metro Health Management team, and the initial idea was for the mapping. We initially mapped some facilities to the Metro Hospital, but thinking through after 1 year, we saw that why don't we leave it as a hospital without border, so that facilities could be referring their cases to the place, so that they will also perform their supervisory role. So after 1 year implementation of this network of practice, Metro Hospital became a supervisory center to the health facilities. And the late Mesu, I think we visited some of the facilities during the implementation stage. So just as it is, its main role is to perform the supervisory, clinical supervisory activities across the metro, and looking at where it's located, mapping 1 or 2 facilities at the Elisadale sub-metro, it is not going to help. So that's the main reason. It has a role to play in the networks as a medical supervisory facility.
Well, I think Director has thrown more light on what is happening at Metro, but what comes out is that you have come to tell us that you are not playing your supervisory role. You are not restricted, as it were, in performing your supervisory role, but the fact is that you have not taken or availed yourself of the opportunity of doing that. Because by the structure, you are not a hub. And yours is more supervisory, as it were, also helping in building capacity of the lower facilities. But here you have admitted that over time you have not been, avail yourself of that function. And so you can't blame anybody for the fact that you have not played your role. So I think you need to go back and then, as it were, strategize and go back and play your role as such, and you won't have any problems.
Right. Thank you very much for all your questions, suggestions, and all that. So we'll move on to the next presentation, and that will be done by the representative from the Coheti Group. Please, if anybody is here, Coheti Group. Okay, sir, you're here. Thank you. Please, let's give it up to him as he walks here.
this one. Combine.
So go ahead with your high-powered delegation. You have 20 minutes to deliver.
Good morning, everyone. So this is a presentation by Coheti Central Region. My name is Mr. Abed, and these are my So we have a presentation outline. So we're going to talk briefly about the background of the colleges, the accreditation and programs they run. We are also going to talk about their clinical training, learning environment, innovation, best practices that we do, partnerships that we have, challenges, way forward, and finally, conclusion. So for the school, we have the oldest amongst us being Kepus NTC, which was established in 1948. And then we have College of Community Health Nursing, which was established in 1975, with Psychiatric Nursing Training College, ANCAFO also established around the same time. And then we have Triple Praso, established in 2007. And then Dunkwa Nofin, 2009. And then finally, Asin Manso, 2019. That's our baby school. So we have accreditation and programs. So for the various schools, most have had their accreditation, that is from GTEC, and then they are also regulated by the Nursing and Midwifery Council. So you can see from the slide we have for Winneba, they run BSc Nursing, BSc Public Health Nursing as well, and then they run the old program, that is the Public Health Diploma, Nurse Assistant Preventive. And then for ANCAFO, we run the two programs, that is Registered Community Mental Nursing and then Registered Mental Nursing, all being diploma programs. We are still having our documentations to do our BSc Mental Health Nursing. It's not finalized yet. So we have our sister school, Triple Praso, also having BSc Public Health Nursing, and then they also have the old program that is Registered Public Health Nursing Diploma, Registered Midwifery, Registered General Nursing. And then Kepus NMTC also runs their old two programs, that's the Registered Midwifery and Registered General Nursing. So for Dunkwa Nofin, they run BSc Midwifery, BSc Nursing, and then also BSc Public Health Nursing. And then they have the old program, that's the Registered General Nursing Diploma, Registered Midwifery, and then Nurse Assistant Clinical Certificate. And then for Asinman, they run the Registered General Nursing and Registered Midwifery program, diploma. So for clinical training and learning environment, most of the schools have their clinical training in accredited health facilities with supervision from qualified professionals who are preceptors. And then for our intra-semester clinical experiences, we use nearby facilities that we sign MOUs with. And then during a vacation practicum, students would choose health facilities that are in their place of residence or around their place of residence so that they can do the practicals there. For monitoring and assessment, we make sure that tutors go on clinical supervision around the country to make sure that the students achieve their clinical objectives. The schools also have simulation laboratories and then libraries and then computer labs, which are resourced to help in this regard. Okay, so for our staffing needs, it's in a table, and most of the schools have inadequate tutors. So we fall mostly sometimes on part-time or some of them who are casual, so the figures speak for themselves. With our sister school, I think man being the most deprived of tutors, you can see from them. They only have 10 students, and they have to fall a lot of temporary and part-time staff. And then also, with our staffing needs, we have a challenge with the increasing number of temporary staff. You can see the numbers are 118, which drains our IGA. So with best practices and then innovations for school, Ankafu School, we have incorporated into our LMS, that the learning management systems, a feature that can allow students to have real-time feedback so that they can appraise their tutors, so that the quality assurance will be able to use that to improve upon best practices. And then for our sister school, Winneba, they instituted a strong and rigorous continuous professional development for all tutors and managers. So they encourage training both in and out for their staff. And then for Triple Praso, they have enhanced their access to learning resources, and then they also strengthen their clinical supervision this year. So for Cape Coast NTC, they have been able to have most of their lectures online, and then as well examinations. Their school is a hub for NMC examination. So even Ankafu goes there to have exams with NMC. I think Manso also have short successes with strong partnership because they are a new school and their needs are a lot. So they strengthen their partnerships and it's helping them in that regard. We also collaborate with partners that the NMC and NGTech, and they've always been keeping them on our toes. So with most schools having their policy direction and doing the BSc programs, we have a strong relationship with them, and they keep us on our toes and they direct us as to what to do. So we are both exposed to them. So we collaborate with them. And then with the MOH and the NMC, they also help us in that regard. We also have institutional partnerships with hospitals where our students have their practice, and then the polyclinics and other sister institutions. We also support clinical practice with other institutions for affiliation programs. So we are also affiliated to various universities, namely UCC, NUST, and UG. And they help us to maintain academic standards, as well as they help us with our curriculum. And then we also maintain partnerships with the local governance structures, and then we have a strong community engagement with our MCs and the municipal assemblies. With every institution, we have challenges.
And most of our challenges are around land encroachment, because most schools have vast lands, but because we have challenges with our development, most people have encroached upon our land. So most of the schools are bedeviled with this development. We also have inadequate teaching staff, which was showcased in the case of Asinman and in other schools. We also have inadequate classrooms, and then we also have challenges with the hostels, because students' numbers have risen, but we don't have requisite accommodation to house them, so it is also a challenge for us. Our vehicles have aged. We keep up by maintaining them, but it's always been one of our challenges. So we want that they give us new vehicles. And then there are numbers who are not enough. And then with the housing, especially for some of the principals, they don't have accommodation in that regard, so it's a challenge for them. Funding constraints has always been around our needs. And then also, with the ICT facilities and internet connectivity, most schools have done a lot in that regard, but we still have challenges, because sometimes the bandwidth is not enough for the increasing number of students. So we always try to procure, but we still have challenges, so it's a problem for us. So the way forward, we secure financial and technical support for our key projects through external and public-private partnerships, secure financial clearance for our temporary staff, and recruit more tutors, and then provision of vehicles and buses for administrative, domestic, and conveyance of students to clinical sites, as well as the continuous professional development programs for tutors to align with the emerging nursing practices. So, so we also have ways of improving IGF by investing in projects that can generate income. Some schools have suggested pure water businesses, and so we want to look in that direction. And then we also want to adopt innovative teaching strategies and technology to improve the production of competent health professionals. We also want to increase our clinical size to match up with the ever increasing numbers of our students, and also improve ICT infrastructure. We also want to strengthen already existing relationships with our stakeholders and look for more partners. So we'll be looking out to COICA. Today we are here. That they will look in our direction. So in conclusion, we all know how the ATIs are helping in the training of competent nurses and midwives to support the ever-changing and demanding needs of healthcare. So we, through our clinical training and then affiliation, academic affiliations and then regulatory bodies, we contribute to the development of Ghana's healthcare workforce. But we also face a lot of challenges in doing these mandates, as we have limited staff, inadequate infrastructure, and then also insufficient funding. So to address these challenges, we are preferring that the government should increase support to us and then help us to improve our infrastructure, and then also help with the staffing needs, because we have a lot of people who have upgraded themselves, but the challenge is with the health training institutions to put staff to us. Thank you very much.
Yeah, thank you very much, Betty. We will just take 3 questions and comments, and then we'll take the last presentation for this session, and then we'll go on snack break. I'll take the first question. So after I'm done, I'll be only 2 more questions, and I'll allow. Yes, let me enjoy the privilege of being the chairman for this occasion. Yes. I just want to find out from Coheti, is there a particular reason why you are not able to, as it were, attract or get enough teaching staff? I was thinking your area is one place that, a lot more people would want to, as it were, move in there as, teaching staff. Is it an issue of clearance, getting the clearance, or is it an issue that people rather prefer, coming to support the teaching staff on local basis for, whatever reason, I don't know. But what is the real challenge? And then the second question, it's all part of tied to this. In terms of infrastructure, I think you did say that you didn't have enough infrastructure, particularly accommodation for students. Is it not a matter of you probably enrolling more than you actually require, rather than looking at infrastructure as not being adequate? What is really the issue? So can we take questions from
maybe related, I wasn't going to ask this, so it's not my question, but related to what he was saying about the numbers you're taking. We also know that on the other side, there's a huge backlog that has not yet been taken up. So within your sector, are there discussions ongoing about what are the ideal numbers to be training? I just want to know whether something like that related to his point. But anyway, your main challenges you itemized on your last slide. Very important one, very valid ones. Limited staff, inadequate infrastructure, insufficient funding. And I think they should all be addressed. Nevertheless, in this meeting, we cannot solve those ones. I want to know, in your engagement with our facilities, are there any peculiar challenges you think as a group we can help address? So that at least we go out from this meeting able to solve something related to what you want to do. You mentioned something about increasing sites. Maybe you can give us more details on what you are thinking about and how we can also help in that regard. Thank you.
Okay, thank you very much. I believe strongly that the training institution is good. We are having a lot more engagement now, because sometimes people are sent to you regardless of the space you have. It's a bit disturbing. So it's good so that we can bring out the issues we also have. My concern has to do with okay. Please, I'm Dr. John Dasmens, medical suit, Albina Government Hospital. My boss is Dr. Benedict Kwao, Anchor Full Procedure Hospital. So you know that we are very much interested in your presentation. Okay, so now everything about health is going into e-health, IT, and all that. My concern is there a system in the training institutions where the nurses that are coming out are abreast with the situation on the ground, or they have to complete and come back to us for us to take them through the orientation, or there's a system that's already in place ensuring that these people come out IT inclined? Because now We don't want people to come and the only documentation they know is the bedside list. Thank you.
I think we can get the responses. I said 2, but I mean, once your hand is up, you will not ignore it.
Thank you. Since I'm lovely, flying. Next manager for Brapa Polyclinic. My question has to do with MNSEC. The full name is, or the full meaning is Nursing and Midwifery Clinical Education Coordinators. Formerly, we used to refer to ourselves as the preceptors at the clinical field. I want to ask the boss that Cohety, what kind of provision do they have for clinical educators, for preceptors at the field? And we speak to the nursing training colleges coordinators that they should find a way and remunerate those of us at the clinical side who extend the training, because the training is both field and in the classroom. When it comes to the field, we do that on our own because we have the passion to do. And those of us who have the passion, we also recruit other nurses, and we have to speak to them to understand the fact that it is part of the training. But formally, what provision does Cohety has for nursing and midwifery clinical education coordinators? Thank you.
So, Cohety, I think we can give us some responses.
Thank you very much. My name is Selassie Kikovice, a health information officer. I want to suggest to Cohety that they don't have challenging lecturers. They don't have challenging lecturers because they are in health. And everything they need to teach their students, health we have. But it's because they've created a system that if they are not a nurse, don't come and teach. That's their problem. And certain courses can never be taught by nurses because they will not go into that field. And they will come and still struggle with us. So I think this, for me personally, I took this as a personal agenda. Because when you can bring your staff to my office to come and learn something from me, and I cannot teach that student in your classroom, if you come, I'll tell you go. They don't have problem with lecturers at all. If they will change your orientation, they will have enough lecturers and they will even don't know what to do with it. Thank you very much.
Yeah, Cohety, so now we have your responses.
Thank you very much for the question. For the reason why we are not getting the numbers for the numbers that the tutors coming to the colleges, I think it has to do with the health training institution directive. It's a process. Most people have upgraded themselves, but the issue has to do with the fact that they have to go to the schools and their competencies or their specialties are also very key. If you do a first degree in medicine, that doesn't mean you should be recruited. You need to have a master's which will align with the BSc program direction. So that is also a challenge now. Either two, they were taking first degree, then you be there, and then you upgrade yourself. But they now have a new policy direction where the list should be a master's and it should be a specialty. So that is also the challenge. And then with the clinical side, that we said we want agencies in the number. It's school specific. It's school specific. For instance, if it's a midwifery school, we want expansion, if they are military facilities, we want more of those facilities to be rolled on. So it has to do with signing of MOUs. And I think we would have to take the first step to signing those MOUs with the facilities. So that is what we are doing. Because of the we have MOUs, already existing MOUs, but it was restricted to the numbers available at the time. So now that the numbers are increased, we want to sign on more so that it will address the specific needs of the specific specialties. And then, I think the last one. Okay. Yes. Yes. So most of the courses in our curriculum, most of them are nursing. We have general courses that anybody can teach. So, for instance, if it's nutrition, I don't expect a nurse to teach. We can bring on a nutritionist. We do that sometimes, but sometimes a burden on us. So sometimes we co-opt nurses to teach that. But I know GTech is trying to streamline those things. So if it's nutrition, it should be taught by a nutritionist. And if it's pharmacology, it should be taught by a pharmacist. I think elsewhere, that's what they are doing. So we want to follow these best practices. So what it means is that going forward, we will attract more different caliber and cadre of health professionals to teach in our schools. So be rest assured that it's not all going to be.
So the question that Mr. Kovice has made his personal agenda, he is health informatics, health information. Would you need such persons
yes.
to also train?
Yes. Okay, my boss will answer.
Good morning, everyone. I think the next the informatician talking depends on the staff we have in the school. And remember, nursing is not winding up. You have nurse informatician, you have nurse pharmacologist, and all that. So if I have a nurse who has done PhD in pharmacology, that nurse will teach the course for the nursing student to understand it better. If I have a nurse informatician, that person will teach. Other than that, then the IT man will come and the nurse will support. Because we are doing nursing informatics with our nursing process in that regard. So he cannot come and teach nursing process because it's a link up. So we bring the two and make them. But know that nurses are also abusing themselves. Thank you.
Yes, but I want to find out, do you have all these fine specialties, especially which is the process?
Yes. And we have them. If you talk about there's a course called disease control. Disease control is not supposed to be taught by a disease control officer, no. It should be taught by a public health nurse. If you look at the content of the curriculum, you understand that the things there are more of diseases and its way forward. So I will not call a disease control officer to come and teach disease control and management. So please understand us. We are not doing and right now, even if you are a tutor in a school, if you are a tutor in a school and you have made yourself anatomy champion, no, it will not work for you. You need to go to school. If you want to teach anatomy all the time, you must go to the university and do masters in anatomy. Then you become a master of that program and course. So the IT officers, some of them were wrongly brought into the colleges. So now that we are seeing all these things, we will merge a nurse with you. So the next takes the aspect of the nursing and then the IT man take us through the technicality of the IT, and which have.
Thank you very much. Now, the issue is with the specialties and the various. For instance, let me give you an example. Myself, I was a registered state midwife. But then, I'm Joyce Gifty Archery Principal as a minus in the midwifery school. She is Dr. Hannah Yosen, College of Nursing and Community Health Nursing, Winneba. Okay. So, myself, I was a state registered midwife, the old state registered SRM. I wanted to teach at the training school. I was asked to go and do BSc midwifery, even though I had done SRM. I went back to school to do BSc nursing, and because I wanted to teach midwifery, I had to go back and do BSc midwifery. Auntie Hannah just graduated in BSc midwifery, MPhil midwifery. I had to go back and also do MPhil midwifery and then MPhil nursing to be accredited to teach at the school. So that is the challenge we are having now. If you want to teach at the school, then you should be a specialist in that field. If not, the tech are always on our neck. So IT, we have to get somebody who is specialist in IT and then informatics attached to a nurse so that he teaches the IT aspect and the nurse teaches the other aspect. For instance, we have a course like entrepreneurship. Entrepreneurship, when you bring a business person, he will teach it as a business. But we are talking about the health facilities being a non-profit organization. So when they come, you bring somebody who is a business person to come and teach IT in the school. We have to look at a nurse who will be able to blend the two. So that we can get a very good result. If not, then the person come out and then we don't have this problem.
One of the colleges, team, community happiness.
You want to say?
So about the lack of tutors in the school, I think a lot of people have come around. They have applied to the ministries, that's the healthcare institution, and they are working towards the accreditation process to get them posted to us because of the intention that we need to move all the schools into the new program. For that matter, some of us have to go back and be bridging the gap. So if I stand there and I'm having 3 masters, you will not understand because it was not worth what I was holding earlier. So they need to go back again. Some of us have 2, 3 degrees. Some of us have 3 masters. And you have public health, everything, because you were having beard. And you will not be allowed to do MPhil medicine. So you have to go and do BSc something, go back and do MPhil. Even after the PhD, you go back and all that. I am still doing PhD nursing again. Because I want to align myself. I don't know who will call me one day. Thank you.
Thank you. I think we can let this matter rest. What I thought was that there was this staffing gap, and for that matter, basically, yes, there was this staffing gap, and so we could really get other people there to come into. But if you say you have the specialties, as you say, then who am I to complain? But there's one question that has not been answered. I think the answer about the preceptors. What motivation do you have for the preceptors who train the students who come to the facilities?
Thank you very much, Honorable Chair. I will also plead, now that Mr. Obi Yeboah is here, when you see our applications at your office for release from Ghana Health Service, we are begging of you, please release us for us. We are begging. It's our humble plea, please. And the medical directors and the medical suite, please, when you see our application, please kindly release them for us. If not all, but you can help us in that regard. And then talking about the preceptors. For the preceptors, you know, for us as a health training institution, on our fees that we collect, is the same fees that we use to do everything in the school, from structure to paying and everything. We don't have anything coming from the government. We don't have anything from outside. So the preceptors, we don't have actual fees that we pay or allowance that we give to the preceptors. But we engage them during our end of semester practicals and NMC examinations so that we will be able to pay them, give them allowances. So that is an issue. We are still talking with Director TI so that he could formalize some of these allowances to our preceptors. In fact, they are doing very well, and we need to give them allowance. But we need an official authorization from Director ATI before we can do that. Thank you very much.
Right, thank you very much. I am Vincent Shamonti, NMTC Chufupras. I just want to add up. I think my colleagues have said a lot. To add on the clinical supervision. In fact, we want to say a big thank you to our clinicians, everybody at the clinical side, right from the security person to the medical. You are all doing your part, helping us to train them. What I want to just leave with you is about the clinical supervision. You supervise them not only during a school, when we are in school. It's both intra and inter-clinical practical. So we are in school, they are there. We are also in school teaching, so at a point in time, we rush to the hospital to see them. What about during the holidays? We try to do that and get them all, go around, but it's difficult. Transportation and all the risks involved is very difficult, so we try to do that. But I just want to put a humble submission here. I think Greater Accra Region also, they have that in practice. So they link up. They link up with, for example, I'm in Chufuprasu. So with Chufuprasu,
maybe during the holidays I'm there, or most of my teachers are there. But some of my students are in Sogakope, Volta region. So we link up with the clinicians to do the supervision on our behalf and then give us feedback. But that's the evaluation. There is a form that we use evaluation for. We want to make it in such a way that it will be formalized. Evaluation forms, some places they package it and give it up to the student themselves. We don't want it that way, so some of us at certain points, we try to stop that one. Keep it, we want to network. Of late in Ghana, we cannot be doing things on manual basis. So we scan forward to the schools and so on and so forth. Yes, and payment. Another one is on this, on the examination, as my sister rightly said. It's not only the NMC and this one. Sometimes the end of semester examinations also count. We still fall on due. I think Koheti is trying to bring out something, a zonal aspect. So we zone, or we group ourselves into various zones, and then preceptors will share or discuss, so that even though you are far away, you are not the preceptor for NMTC Chukwuprazu, but alongside, you end up examining or trying to supervise them and then sending feedback to us as well. Thank you very much.
All right, thank you. Your suggestion well taken. Koheti, I think it's been a good discussion. So you are now discharged.
Thank you very much, Koheti Group. Right, vehicle number CR 697W, please. The information reaching is that when you've parked, it's not really good. So please, if you can, repark well. Vehicle number CR 697W. Thank you very much. So at this moment, we'll have to break for snack. Then we come back for our panel discussion and some presentation from St. John's and Private Health Facility Association of Ghana. So please, we are breaking currently to have our snack break. So you are right down there, you take it, then you go to a certain area. We have 15 minutes for our snack, then we come back for the next. Yes, please use your coupon. Okay, I think everybody have it. And the SMC will be at the conference room. So we'll be led by an usher team. SMC and invited guests will be at the conference room, and that will be led by an usher to take you to the conference room.